Today we are going to look at the Cushing's disease. Last time you were there when and this one is functional testing is done. Okay. Now, remember that in Cushing's, the commonest thing is ACTH dependent Cushing. That means coming from above. Whereas ACTH independent from the gland is lesser. In thyroid, the reverse. Thyroid hyperfunction, mostly it is from the thyroid. Very rarely it is a TSH secreting tumor. Here, the corticotrope secreting Cushing's is more common. That is the ACTH. Dependent Cushing's is more common than the primary adrenal Cushing syndrome. Cushing's disease from above, Cushing syndrome from the adrenal. So corticotroph adenomas or Cushing's disease, they account for nearly around 75% of the cases there, as you can see. Cushing's disease, ACTH producing pituitary adenoma, 70 to 75% of them are from the ACTH from the pituitary. So rest 15% are ectopic ACTH. That means the ACTH is coming not from the pituitary, but it is coming from the bronchial or pancreatic carcinoid tumors, or it could be small cell tumor of the lung, or it could be medullary carcinoma of the lung, or pheochromocytoma. Medullary carcinoma of the thyroid, or pheochromocytoma. These ectopic sites also produce ACTH and produce around 15% of the Cushing. Remaining 10% are ACTH independent Cushing, and out of them, adrenal adenoma, adrenal carcinoma, and then rare causes are macronodular hyperplasia, primary pigmented nodular hyperplasia, and then these are the other rare causes. So if I get a patient with Cushing's disease or Cushingoid feature, the first diagnosis is iatrogenic Cushing's. Most likely it is steroid from outside, it is producing the Cushing. That we have to exclude. After that, the next common one is pituitary adenoma, then the ectopic ACTH, and finally a small 10% of the patients are from the adrenal gland proper. Okay. There are two challenges in the diagnosis of Cushing syndrome. One is to distinguish the patients with cortisol excess, physiological excess versus pathological excess. Physiologically, there are several states where the cortisol levels rise. So we have to distinguish the physiological excess from the pathological excess, and also to determine whether he is having ACTH dependent or ACTH independent, and among the ACTH dependent, again, is it ectopic or is it from the pituitary gland, and in the adrenal ACTH independent one, is it adenoma or carcinoma or other micro or macronodular hyperplasia. So what are the various signs and symptoms that one can see? Body fat, that is weight gain. So it will be more than 115% of the ideal weight. 80% of the people will present with weight gain or obesity. Skin changes, facial plethora, thin and brittle skin, easy bruising, broad and purple stray on the abdomen, acne, hirsutism. These constitute around 80% of the people will show skin changes. And moon face also. That means patient's face is rounded, and 75% of people. Hypertension may be a feature, purple skin, hirsutism, and then menstrual disturbances, and then plethora of the skin, abnormal glucose tolerance, GTT abnormal. Because of cortisol, they will have secondary diabetes, impotence, muscle weakness, proximal muscle weakness also is very important. Weakness of the proximal myopathy is very common. Prominent atrophy of the gluteal and the upper leg muscles with difficulty in climbing chairs, getting up from a chair. This is because of the gluteal and leg muscle weakness. This is called proximal myopathy. Proximal means nearer to the main skeleton. Distal means this. Okay. So what did we learn? Obesity, thin skin changes, moon phase, hypertension, purple skin, hirsutism, menstrual disorders, and then skin plethora, abnormal GTT, impotence, proximal muscle weakness, then cardiovascular end is also very what sort of things? Hypertension, hypokalemia, water retention, edema, and atherosclerosis, aggressive atherosclerosis. One reason is hypercorticism. So in the metabolism, I have already told you glucose intolerance, diabetes, and dyslipidemia. A reproductive system, there will be decreased libido. Women with amenorrhea due to cortisol-induced inhibition of the gonadotrophin. Why amenorrhea? Because excess cortisol inhibits the pituitary. Pituitary has got same common pathway for the sex steroids as well as for the adrenal gland. So sex steroid inhibition produces reproductive changes. Central nervous system involvement with irritability, emotional lability, depression, sometimes cognitive defects. In severe cases, paranoid psychosis can also occur. Another important metabolic feature is osteoporosis because cortisol by itself is a catabolic hormone and bone withdrawal occurs and osteoporosis can occur. Edema of the lower extremities, hyperpigmentation of the skin, hypokalemic alkalosis can also be there. So blood and immune system increases susceptibility to infections, increased white blood cell count, eosinopenia, very important. Because whenever we have eosinophilia, we give steroid to reduce it. Here, hexasteroid, eosinopenia, almost not seen. Hypercoagulation with increased risk of deep vein thrombosis and pulmonary embolism. Now, before the stepwise approach, there are a few points I wanted to make. Come. So, the stepwise approach to the diagnosis of Cushing's disease and syndrome. Clinical suspicion and screening for hypercorticolism. So, first of all, whoever has got the features that I have described in the previous slide, like increased body fat, skin changes, bone changes, muscle myopathy, hypertension, hypokalemia, metabolism with glucose intolerance, dyslipidemia, reproductive system involvement, central nervous system involvement, bone and immune system, osteoporosis. Any of these features, you should suspect clinically that it could be Cushing. Then we have to differentiate this from endogenous hypercortism from exogenous source. That means you have to ask the patient whether he is taking any steroids for any reason. So that you exclude. That is exogenous hypercortism. Then endogenous hypercortism, determine the source of the endogenous. This is the difficulty. The source, as I have told you earlier, you see this, ACTH dependent Cushing's is 90% of the disease is ACTH dependent, out of which 75% is Cushing's and then 15% is from the ectopic ATH. Only 10% is from the gland per se with adrenal adenoma, adrenal carcinoma, and other micro and macronodular disease. Okay, ACTH dependent and ACTH independent. You should be able to separate ACTH dependent versus ACTH independent. ACTH Cushing's disease again should be classified into ectopic and from the pituitary. Cushing's disease and ectopic. And ACTH independent Cushing's, there are 3 or 4 etiologies: adrenal adenoma, adrenal carcinoma, micro and macronodular hyperplasia, and things like that. So how do I go about? Last time we have seen It is not just measuring one cortisol sample somewhere and then coming to a diagnosis here. So here, the UFC, that is urinary free cortisol, UFC, has to be measured as we have seen last time. 24-hour urine free cortisol can be measured, and which is a very precise and cost effective screening test. Okay, supposing I am not able to do 24-hour collection. Alternatively, you can do a plasma cortisol overnight 1 milligram dexamethasone suppression test can be used to identify patients with hypercortisis. Okay, that is called the 1 milligram dexamethasone suppression test. That is called the LD. Then is the low dose. Low dose is 0.5 milligram 6 hourly. You give for 2 days and then look for that. Okay, and then the cortisol levels are at the lowest in the midnight compared to any time of the day. That is why we see whether there is excess cortisol in the saliva at midnight. That is the salivary cortisol. Because normally it is lowest in the midnight. So the nighter levels are seen in the midnight. So elevated midnight salivary cortisol is suggestive of Cushing's disease. So if any one of these tests is positive, then of course you repeat the other 2 tests and confirm the diagnosis. Then once the hypercorticism is known, then we have to evaluate what is the status of the ACT. Why 90% of my cases are due to ACTH excess. And only 10% of the cases are from the adrenal gland. That ACTH excess can be from the pituitary, maybe from the ectopic. So pituitary adenomas notoriously are very small in size. They may be less than 4 millimeters, and routine MRI may not detect the pituitary adenoma. So then how do I go about that? So blood ACTH levels have to be obtained, and these distinguish the independent ACTH independent tumors from ACTH dependent. ACTH dependent means pituitary and ectopic. Independent means adrenal or exogenous glucocorticoid. Okay. The mean basal ACTH levels are about 8-fold higher in patients with ectopic ACTH than those with pituitary ACTH. That means the ACTH levels are uncontrollably higher in the ectopic part. So the moment we see the ACTH levels, we should know, yeah, this is very high ACTH, must be coming from lung cancer, maybe pancreatic carcinoid, maybe some other source. Thyroid, lung, pancreas are the source. So the mean basal ACTH levels are an indicator that it is ACTH dependent or ACTH independent. Then how do I separate between the ACTH from the pituitary and ACTH from the ectopic source is by looking at the ACTH suppression, whether the ACTH can be suppressed by dynamic testing and using glucocorticoid feedback and ACTH stimulation in response to CRH. Either you give CRH IV and look for the ACTH increase if it is pituitary, or you do inferior petrosal sinus sampling and see the gradient between the central and the peripheral. The central and peripheral gradient is at least 2 to 3 times in case of pituitary, whereas it is same when it is coming from outside. Because it is some other tumor and it equally circulates into the petrosinus as well as. Whereas if it is pituitary, from the pituitary the ACT is directly coming into the venous sinus, there the levels will be higher compared to the peripheral. So that's how I distinguish. Inferior petrosal sinus sampling is not a very common procedure and also not an easy procedure. Only trained hands can do a bilateral, both sides you have to take. Because if the adenoma is only one side, then it may not drain into the sinus proper. So you take both sides, mix that blood and then. Okay, so gadolinium enhancement of the pituitary is one newer technique with the MRI. MRI with gadolinium enhancement. So anything less than 2 millimeters of size, the MRI will not be able to detect. So what we have to do is then bilateral inferior petrosal sinus ACTH sampling before and after the CRH. CRH will prime the pituitary and you will get more of the ACTH in the petrosal sinus. Whereas if it is ectopic, it is not influenced by the CRH. So ectopic one is not under the CRH, whereas the pituitary one is under the CRH. So CRH suppression. CRH, this one will be differentiating between the two. The gradient will be 3 times or more in case of pituitary one. It will be less than that in case of ectopic one. This is what you have to understand. Now, clinical manifestations of hypercortism are the result of altered, that is the quality, the rhythm and excess cortisol quantity. However, how are we getting the clinical manifestations? That is because of the rhythm has changed and also the excess cortisol. Normally, the cortisol secretion is episodic. It comes whenever there is a need for the cortisol and then it is suppressed. Whereas in case of these diseases, the cortisol is 24-hour elevated. So that results in metabolic changes in the body and various skin changes, various sex changes, various weight changes and all that. Hypercorticolism has a broad spectrum of manifestations. Overt Cushing syndrome is easily recognizable. Somebody is having very clear-cut Cushingoid features or Cushing features. It is very easy, but it is difficult to delineate the subclinical forms from patients with obesity, diabetes, hypertension. Because diabetic people are obese, they have hypertension, they have dyslipidemia, they have skin changes, they have mental depression, so many things. Hypertension per se may be secondary due to Cushing, maybe primary hypertension. That's why, if it is subtle and in the middle path, that's not very clear cut, then you have to be very careful. Findings like visceral obesity, glucose intolerance, hypertension, menstrual irregularities, though common in Cushing's, they don't discriminate Cushing's from the other similar conditions. Specific manifestations of hypercorticism are those affecting the skin, lividity, livid striae, ecchymosis, proximal myopathy, myopathy of the thigh muscles, myopathy of the gluteus, myopathy of the shoulders will be there. Vertebral compression fractures, and then they may be having osteoporosis also. Catabolic features, because it is a catabolic hormone, they are very subtle in the early course of the disease. With long-standing and intense hypercorticism, they may be manifest. Hypercorticosis or hypertrichosis over the forehead is a useful clinical clue. What is hypertrichosis? Here, normally nobody will have it. These people will have hypertrichosis of the forehead. Yeah, and also women having beard, Lawrence Moon-Biddle syndrome. Hirsutism, that is hirsutism. This can occur in both sexes. Okay, that may be a clinical. So how do I screen? Endocrine Society guidelines recommend screening under the following circumstances. Patients with multiple, progressive, discriminatory findings suggestive of Cushing. There must be multiple system symptoms, they must be progressive, and they are discriminatory towards Cushing. Okay, cases with unusual features like hypertension and osteoporosis in a young age should make you suspect endocrine cause for the hypertension, either thyroid excess or steroid excess. You have to see. Adrenal incidentalomas. What is incidentalomas? If a patient underwent a scan and the radiologist reported there is an adenoma in the right adrenal, 5 millimeter. It's an incident. Usually, adrenal tumors or adrenal adenomas are not symptomatic and they constitute only 10% of the total cases of Cushing. So, incidentalomas also are possible. Children with decreasing height percentage, those who are not gaining height, and they are all right at 5 years, by 10 years, he is compared to his peers, he is having lesser height. And that is what is called screening. Subclinical CS is seen in 5 to 30% of cases of adrenal incidentalomas which in turn are found to be 4 to 7% of the adult population. Screening every diabetic patient for Cushing syndrome is not recommended, even though the prevalence of occult Cushing is up to around 10%. Okay. Then establish. First thing is we have to suspect. Second thing is rule out exogenous hypercortisolism. Third thing is keep the clinical features in mind and start screening for those who have suspicious or definite clinical features. Then establishing endogenous hypercortisolism. This is the second step. That means you must demonstrate that there is an excess of steroid in the body. Exogenous glucocorticoid history is imperative to rule out exogenous use. So every patient with Cushingoid or Cushing syndrome like thing, a history about prolonged glucocorticoid use has to be elicited and that should be ruled out. In India, cases of exogenous use are commonly encountered because secondary to ingestion of powdered or injectable medications for pains and aches dispensed indiscriminately. Here, there is no prescription limitation. You can go and buy betanol tablet or dexamethasone tablet in the market. They will give. Whereas in Western countries, it is not available. Here, indiscriminately, once they use it, they feel happy. They'll continue to buy and use it, as I told you in my last experience. Some features such as increased intraocular pressure, cataracts, benign intracranial hypertension, aseptic necrosis of the femoral head, osteoporosis, pancreatitis are commoner in the iatrogenic than in the endogenous Cushing. Endogenous Cushing generally do not have cataracts and benign intracranial hypertension and aseptic necrosis. History of depression, severe obesity, chronic alcoholism may suggest pseudo-Cushing, irreversible HPA, that is hypothalamo-pituitary axis, and hyperactivity. Usually such cases are clinically mild and they may show suppressed cortisol, dexamethasone suppression test, and reverse to normal with treatment of the underlying condition. Now, we have seen the diagnostic testing, but in relation to Cushing's, we are again saying the tests available are quantitative estimation of the cortisol load, 24-hour urinary free cortisol. Correct 24-hour urine, look for urinary free cortisol. To assess the circadian rhythm and the quantity of the HPA axis, midnight serum cortisol or late night salivary cortisol tested. Midnight blood sampling may be difficult, but midnight salivary sampling is easier. The suppressibility of the hypothalamo-pituitary axis is judged by the overnight dexamethasone test, suppression test. That is called ONDDSS, ONDST, overnight dexamethasone suppression test, or simply called ODS. Standard 2-day load dose of dexamethasone. Here you give 0.5 milligrams QID for 2 days, whereas in overnight you give 1 milligram overnight in the before night, and next day you test for the cortisol. So, and another thing is CRH stimulation to differentiate pituitary from the egg. Now, tests for diagnosis of endogenous hypercortisolism. Now, what do we have? We have the 24-hour urinary free cortisol. 2 samples must be obtained. Sample collection should be complete and refrigerated until analyzed. Cutoff upper limit of the normal SA specific sensitivity is 90%. Specificity is also very high. So, it becomes a very easier test to do. Drugs like carbamazepine, fenofibrate, excess water intake, false positives. False negatives due to renal impairment and mild Cushing. Okay. 24-hour free cortisol advantage. Late night salivary cortisol, buccal cortisol, 2 samples between 11 p.m. and 12 p.m. midnight are either by passive drooling or the salivating method. Passive drooling means patient can be encouraged to collect the saliva and give it, or you can put the buccal pad and the salivating can be taken. So here the levels are also given, and then sampling midnight serum cortisol. This can be taken a blood sample, that is the patient has to be admitted because somebody has to collect the blood in the midnight, So that is the challenge. And overnight dexamethasone suppression test, 1 milligram at 11 p.m. and serum cortisol at 8 a.m. Okay, standard 2-day low dose dexamethasone suppression test. More than 40 kilograms, you give zero point 0.5 milligram every 6 hourly for about 2 days, and less than 40, you give 30 micrograms per kilogram body. Why the this one? Pediatric evaluation. If you give 0.5 milligrams, it becomes a higher dose. So you have to use a lower dose for it. Low dose corticotrophin releasing hormone 2 hours after the last dose of dexamethasone, IVCRH 1 microgram per kilogram per body weight is given, and serum cortisol levels are measured. Okay. So you have already seen these things in a flow chart last time, but now we are trying to apply them. Initial evaluation requires determination of either UFC or late night salivary cortisol or ODS or LDD in patients with high index of suspicion and unequivocal discordant negative initial test result. Subsequent evaluation of either midnight serum cortisol, LDDS or CRH stimulation is required. In cases of an initial positive result, repeat the test by carrying out the 2 other tests that you have left out and confirm the diagnosis. Now, the flow chart which we have seen. Cushing syndrome suspected, exogenous causes excluded, exogenous steroid use, 24 or UFC, 2 samples, or ODS or LDDS, late night salivary cortisol bloods. Normal, abnormal. If it is normal, still you have a high clinical suspicion, then you perform one of the other 2 tests. If it is low suspicion, then Cushing syndrome unlikely. Suppose it is abnormal, the first test itself, then perform the remaining 2. And if those 2 tests, both of them are discordant or equivocal, then midnight cortisol or LDDSC are achieved. And then come. Suppose the results are concordant and all the 3 tests are showing abnormal result, then it is Cushing. Step 3. Now we have found out first what we did. We had a suspicion. We took all the symptoms, the clinical presentation into account, and then made a clinical diagnosis of Cushing. Then what we did? We excluded people with high exogenous cortisol. And then we confirmed there is endogenous cortisol is very high by 1 or more of the tests which we have listed. Like, UFC and the CODD and the low dose suppression or the CRH suppression, one of them. Now I need to discriminate whether this is coming from the pituitary or this is from the gland per se. For that I require to know ACTH. Is it ACTH dependent or ACTH independent Cushing? Basal plasma ACTH with 2-site immunometric assay is a useful parameter for the diagnosis of disease. You can take a basal ACTH level. Patients with suppressed morning plasma ACTH less than 5 need adrenal imaging. Means what? The stimulating hormone is very low, but cortisol is very high. Means that it is coming from the gland. So you go for an ultrasound and look at the adrenal edema. Normal or elevated ACTH. If it is less than 5 picograms, it is suppressed. More than 15 picograms, it is elevated. It is suggestive of ACTH. Dependent Cushing may be pituitary, may be ectopic. Plasma ACTH values between 5 and 15 are equivocal. If you have less than 5, it is suppressed, all right, go for adrenal imaging. You don't go for pituitary sampling and all. If it is more than 15, it is coming from ACTH is the reason for the problem. So whether the ACTH is ectopic or pituitary, we have to evaluate. Values between 5 and 15 are equivocal. Baseline CRH stimulation test can help to delineate the source in equivocal case. People who have between 5 and 15, then you have a baseline CRH stimulation. What is that? You just give 1 microgram per kilogram body weight of CRH into the vein and then look at the AC. Normally what should happen? CRH should stimulate the pituitary, ACTH should come. In this case of adrenal, it won't be stimulated because it's suppressed by the feedback. In case of primary pituitary, The CRH axis will be still there, and then ACTH will go. Plasma ACTH peak levels are less than 30 after corticotropin releasing hormone. Stimulation excludes the presence of ACH dependent hyper. Then ACTH dependent. Now we have come to ACTH dependent, means the patient has got clinical features of hypercorticism, exogenous corticosteroids are excluded, and cortisol excess is demonstrated in one or more of the four tests. Then we did an ACTH. ACTH also is a high. That is what is called ACTH dependent. Cushing's disease versus ectopic Cushing syndrome. Females with moderate hypercorticism, mildly elevated plasma ACTH, and normokalemic point toward Cushing's disease. That means ectopic means the ACTH levels will be very high. That is one thing. And they are women mostly. They are maybe men, maybe women. And here in this case, if it is CD, that is Cushing's disease from the pituitary, women are 10 times more affected than men. Then there is moderate level of ACTH only, and cortisol levels also not too much high. Elevated plasma ACTH is milder, and potassium is normal. Look at the potassium. If the potassium is normal, then it points to the Cushing's disease. In contrast, a man comes with elevated features of hypercorticism, most likely bronchogenic carcinoma or carcinoma of the pancreas or thyroid medullary carcinoma. Ectopic ACTH. Males presenting with severe hypercorticism, markedly elevated ACTH, hypokalemia, are more towards occult or hidden ectopic ACTH secreting tube. Understand? So a patient has come, he has got features of hypercorticism, exogenous use is ruled out, and plasma cortisol is consistently elevated in all the four tests, and then we have ACTH done. ACTH is not very much elevated. She is a woman, and she has got normokalemia, moderate hypercorticism. Most likely, pituitary is the reason. The other hand, a man comes who has got severe hypercorticism, markedly elevated ACTH, and then hypokalemia he is showing. That means more likely to be ectopic ACTH. Then what you have to do, not pituitary imaging, look for the lung, look for the abdomen CT, lung CT, thyroid scan, those things will be required. To locate the ectopic, okay, magnetic resonance imaging of the pituitary region is the next step. Because when we suspect pituitary, out of the exogenous, out of the ACTH dependent, most common is the pituitary. So that would be the reason. So next will be the imaging of the pituitary. What imaging? Gadolinium enhanced MR. You should ask for gadolinium enhanced MR. There is an emerging data that the spoiled gradient called acquisition technique is superior to conventional dynamic contrast spin echo. Forget about it. It's more a radiological way. You ask for gadolinium enhanced. Reported rate of visualization in the MRI is 50 to 70%. Means 30% of pituitary adenomas are not imageable. They will not come in the MRI. MRI may be normal. Why? They are less than 4 millimeters. Anything less than 2 millimeters, very difficult to detect. Less than 4 millimeters also are missed. But if you use gadolinium, between 2 and 4 also you'll be able to image. That is why the gadolinium contrast. In clinical practice, inferior petrosal sinus sampling is reserved for patients with normal imaging of the pituitary, neck, chest, abdomen. What we would have done by then, we imaged the pituitary. It is normal. ACTH elevated. Corticism present. Look at the chest, nothing is there. Neck, nothing is there. Abdomen, nothing is there. Common ectopic sources are ruled out. And pituitary adenoma I could not pick up by MRI. Then how do I know that it is from the pituitary? I have to do something for the treatment. Then comes the inferior petrosal sampling. Bilateral inferior petrosal sampling. A computed tomography, a scan of the neck, chest and abdomen is performed to to rule out any detectable obvious ectopic ACTH. If the results of the IPS are negative, means what? Negative means what? The gradient between the sinus, petrosal sinus sample and the blood sample should be more than 3. That is positive. That means it is coming from the pituitary. The gradient is negative, means the gradient is not there. It is uniformly distributed. It must be coming from the ectopic somewhere. I have already done chest. I have already done abdomen. I looked at the thyroid. Common sites I could not find. Then more microscopic examination of the whole body. More intense examination of the whole body is required. MRI, CT scan, and probably PET scan are recommended to locate an ectopic source, like something like a neuroendocrine tumors, carcinoid of the thymus, or bronchioles, or pancreas. Sometimes pheochromocytoma itself produces a substance which is similar to the acid. Pheochromocytoma is a medullary tumor. Medullary tumor is supposed to do something with the adrenaline, noradrenaline. Instead, it also produces a substance which is similar to ACTH, stimulates the cortex of the adrenal glands. So, pheochromocytoma, medullary thyroid, also important. Then, adrenocorticotrophin hormone dependent CS. Okay, we have located, found out ACTH excess dependent. A CT scan of the adrenal gland can independent. Adrenocorticotrophin hormone independent. That means ACTH is normal, ectopic source ruled out, pituitary ruled out. Only 10% of the cases fall into the adrenal gland. And what do I do? How to differentiate? Do a CT of the adrenal gland and can phenotype the adrenal lesion as a benign adenoma or an adrenal carcinoma. Benign is adenoma or malignant adrenal carcinoma, depending upon the lipid content and contrast washout character. So the radiologist will image and say, yeah, this has got rich lipid content because of the imaging. This doesn't have that amount of lipid content. Depending on that, the adrenal phenotype, is it a malignancy or is it adenoma, will be done. This is mostly out of those 10%, 90% are that. Very rarely the nodular hyperplasia. These are two types of nodular hyperplasia, which is called the pigmented nodular adrenal disease, primary PPND, or McCune-Albright syndrome, or the other. The nodularity may be micronodular or macronodular. For them, the treatment is only adrenalectomy. There is no other treatment. No. The classical paradoxical rise in cortisol after LDS test is a feature of the PPNAD. ACTH independent macronodular adrenal hyperplasia. There is no tumor, there is no cancer, there is no benign adenoma, there is no malignancy, but adrenal gland in general became hyperplastic. This is called independent macronodular benign hyperplasia. It is a rare familial disorder where adrenal steroidogenesis is driven by non-ACTH peptides like vasopressin, glucose-dependent intestinal peptides like your GLP and those things, and catecholamines and luteinizing hormones. That means what happened? The pituitary gland is secreting cortisol not from the ACTH, but some other stimuli, other endocrine stimulations are stimulating the pituitary. That is the gland, adrenal. This we have seen what are all the various clinical features that one can have. Right from the hair, hirsutism, acne, plethora, psychosis, cataract, mild exophthalmos. Cataracts generally more common with exogenous use, moon phase, peptic ulcer, loss of height due to vertebral fractures, back pain, compression fractures, hypertension, secondary hypertension, centripetal obesity, hyperglycemia because of the glucose intolerance, menstrual disturbances, striae on the abdomen, decreased skin thickness, very thin skin, wasting and weakness of the proximal muscle, easy bruising, exuberant callus formation and fractures, osteoporosis in the young and the aged, tendency to infections, and poor wound healing are various features. So now you see the The one picture A is a retinal computer tomography showing normal bilateral adrenal morphology. Where is the adrenal? This is the kidney there. These are the adrenal, supra-renal, small cap-like thing. You can see arrow-like thing. That is normal morphology. The second picture, that is the B. B is the CT scan depicting right adrenal adenoma. This side, right side is the adrenocortical adenoma, Cushing syndrome. C is the magnetic imaging MRI showing bilateral adrenal hyperplasia. You see the cap-like things have become very big size there. And finally, you see MRI showing bilateral macronodular hyperplasia. Okay. So these are the various things. I have a few things that I need to tell you about these things, about treatment. How do I treat the patient? Management of Cushing's disease is important, having diagnosed. Okay. Now, ACTH dependent hypercorticism, that is pituitary related or ectopic. Then the diagnosis is very clear. Pituitary MRI, petrosal sinus sampling, ACTH sampling has been done. They have found out pituitary adenoma in the MRI. No problem. Knock off the adenoma. Or we could not find out the pituitary adenoma, but inferior petrosal sinus sampling we did, and there is a gradient demonstrated coming from above. Knock off the pituitary. Okay? Consider then, if it is not pituitary, that means inferior petrosal sinus did not show any gradient difference, and there is no imaging is negative, then must be coming from other sources. Then look for the ectopic source and treat the ectopic. Okay, ACTH secreting pituitary adenoma, ACTH secreting other sites, and treat them. Okay, how do I do the pituitary resection? Transsphenoidal surgical resection through the sphenoid bone, surgical resection. The sphenoid bone is in the base of the brain, and the sphenoid bone has got a sort of a cradle. A cradle is called cella. In that, the pituitary is sitting. So I can, instead of going through the brain, it's very difficult. Can go from below and then find out, go into the cradle, pick up the pituitary, and then remove the anterior pituitary. Okay, transsphenoidal surgical resection. Okay. Now, two possibilities will occur after removing. There is a biochemical cure, hypercorticism is cured, and then but there is a steroid deficiency because no stimulating hormone is coming, so you have to supplement the steroid. So, lifelong supplementation of small doses of steroid after cure of the pituitary problem. Or the hypercorticism is continuing. Even after removing the pituitary, my patient did not become better, then he will ask, hey, you have done a lot of big operation, transsphenoidal resection you have done, charging me 10 lakhs, but my problems are where I am. You have to tell the patient beforehand. Some patients will not be able to properly treat. You have so many other complications. You may continue to experience, then in that case, I need to evaluate, but 80% chance you may get cured. 20% it may be continuing. If it continues, what do I do? Then I have excluded ectopic. I have removed already the pituitary. Then nothing I can do. There are medical management. What medical management you can do? If these medical management interfere with steroid synthesis at various hormone levels. 11 beta hydroxylation, 17 hydroxylation, 7 pregnenolone to progesterone to 17 hydroxyprogesterone, all that stuff. So what are they? Pasireotide, and then glucocorticoid receptor antagonist, another drug, steroidogenic inhibitors, pituitary irradiation. 4 possibilities are there. So how much you give those drugs? I will tell. Pasireotide is given in 600 to 900 micrograms per day subcutaneously. What is it? Pasireotide. Pasireotide is a somatostatin analog and a high affinity towards the pituitary receptors. Okay, pasireotide is one drug. The second one is you can use, metirapone. Metirapone also can be used. This also interferes with steroidogenesis and that interferes with the beta hydroxylation. And you have ketoconazole, the antifungal drug ketoconazole has got an effect. An imidazole derivative, ketoconazole, anti-mycotic agent, inhibits the several P450 enzyme pathways and effectively lowers the cortisol in most of the patients with Cushing's disease. Okay. Mifepristone is another drug which you can use. Mifepristone you use in gynecology for for medical termination, pregnancy, mifepristone and mifegest, it is available. Glucocorticoid receptor agonist blocks peripheral cortisol action, approved for hyperglycemia in Cushing's disease. It is a cortisol end organ receptor block. Where the cortisol goes and acts, there it is going to block it. So what are the drugs I have got? I have got pasirelatide, and I have got ketoconazole, I have got metirapone, I have got mifepristone. Metirapone to be used as 2 to 4 grams inhibits the 11 beta hydroxylase. I have already told you. These are the various drug treatments that I have got for pituitary adenoma operated, but still patient is not becoming better. I have still now got pituitary irradiation is another possibility, because any small adenoma which is not picked up by the surgery lurking here and there in the cellular, I can irradiate the pituitary and then cure. Okay. Now, supposing the patient has got a biochemical cure, that means his cortisol levels drop, ACTH levels have, of course, reduced very much, less than 5, and his symptoms improved. Should you leave the patient? No. We have to follow the patient regularly in such that the serial biochemical tests and MRI evaluations are required, because sometimes there is a relapse of the symptoms. In which case, you may have to either use the medical treatment or pituitary irradiation. Suppose all these things fail, what I will do? The fellow who is manufacturing, the factory itself, I will burn. That is the adrenalectomy. Adrenalectomy. So, adrenalectomy is the end treatment for pituitary disease, is a primary treatment for the adrenal. Suppose there is an adrenal adenoma, adrenal carcinoma, adrenal bilateral adrenal hyperplasia. Adrenalectomy is the treatment. Whereas adrenalectomy here is not done routinely, but as a end stage treatment. So this is all about the pituitary. This one, we will go for mineralocorticoid excess next time, or we will go for the hypofunction of the cortisol will go, and then we see the mineralocorticoid. 2 more lectures. We will complete this. Evaluation we have completed last time. This time we have completed the hyperfunction syndromes and their medical and surgical management. And now we are going to look at the hypofunction of the adrenal gland. And then we go for the mineralocorticoid excess also we use.